Good morning. It is a pleasure for me to introduce Dr. Susan Lester from Brigham and Women's Hospital. Just a few words. She asked me specifically to be very brief. This is what I'm going to be, very brief today. So she completed her PhD in genetics at the University of Wisconsin, and then all the other training she did was at Brigham and Women's Hospital, where she stayed, and she's the chief of the breast services in the Department of Pathology at Brigham. She is also a reputed professor at Harvard Medical School, and actually, based on everything I know about her, she has teaching very close to her heart. So Susan, Dr. Lester is very well known for being author of some of the most important books in pathology. I mean, everybody who actually trained in pathology is familiar with the Manual of Surgical Pathology, which is the Bible for gross pathology, gross examination of specimens, and it is used by anatomic pathologists as well as pathologist assistants. But she also is the co-writer of two other important books in diagnostic pathology series. One is breast pathology, and the other one is intraoperative consultation. These are very important books that I personally own and I use very often. These are very important books to have. So I will let Dr. Lester continue from here. So she decided to actually switch from the initial topic that she was going to present, but my understanding is that she will come back for an in-person visit as soon as that will be allowed. So she preferred to have this talk based on cases that are more difficult to diagnose and are potential pitfalls for surgical pathology. So this is a much more practical approach. I would encourage you to use the chat button as part of your Zoom screen, and I will monitor that section. You can send comments and questions either privately through that chat section to me, or they can be seen by anybody. This is your choice. I will compile them and then present in a brief pause after each case the major questions and comments coming from you. Thank you.
Thanks so much, Emil. This is really wonderful, being able to be here at least virtually, if not in reality. All right, hold on. I gotta figure out why isn't this boring. There we go. So I don't really have any disclosures relevant to the talk. The more important disclosure, I don't know if everyone knows, I grew up in Fridley and went to college at McAllister. So I spent many, many years in Minnesota. Some good times, some bad times. So I was there for the big tornado in 1965. Actually, in retrospect, this tornado was heading straight towards our house because we lived right across the lake from the high school. My older sister, Marty, was in the high school at the time when the roof was taken off. So fortunately, our family, our house survived. We all survived, so that was good. Here's 1969. Here's my dad getting his PhD at the University of Minnesota. So I spent a lot of time in his lab. He would bring us in. The thing I remember the most is that he would let us drink pop out of the beakers in the lab. Probably not something approved of anymore, but I remember that being a lot of fun. So I'm really appreciative of everybody who took the time to look at the cases that were sent out with the whole slide images. I do strongly believe learning has to be a dialogue, can't be a monologue. I just don't want to sit here and talk to you. And so being able to scan slides, send them out with links, it really opens up a new dimension in teaching, particularly now that we have to do a lot of the teaching virtually. So I do want to acknowledge Raj Singh and Matthew Hanna, who set up Path Presenter. So all the slides that you'll be seeing today are hosted on their website. And if you didn't get a chance to look at the slides ahead of time, you'll have a chance during the talk and even after the talk. So just the overview of the origin of spindle cell lesions in the breast. So essentially any cell in the breast can be a spindle cell lesion. So we have our interlobular stroma out here outside of the lobules, and they fall into these two families. So there's the CD34 positive family, which includes reactive changes, PASH, myofibroblastomas, and sarcomas. We have this more unusual CD34 negative family, which consists of fibromatosis and nodular fasciitis. Of our epithelial cells, basically there's only one spindle cell lesion, and that's spindle cell carcinoma, and that's going to be important today. But you also have to remember we can have spindle cell lesions from blood vessels, nerves, and smooth muscle as well. If you look at the intralobular stroma, these are the stromal cells that form biphasic lesions. So we have our fibroadenomas and phylloides tumors. So we won't be talking about those today because they're distinct from the pure spindle cell lesions. So when you're looking at these lesions, they fall into the malignant and benign categories. So for the malignant lesions, carcinomas, malignant phylloides tumors, and sarcomas, as long as you're in this group, you're not going to do a tremendous amount of harm if you mistake them. And frankly, some of these are so poorly differentiated that we can't tell them apart. And our treatment is not very effective for any of these. As long as you're in the benign group, you're not going to do much harm because they're benign. So the only one that kind of stands out here is fibromatosis because it does continue to grow. It can infiltrate, but most of the cases that we're seeing now being picked up by imaging don't grow. And actually, it's perfectly fine to observe these patients and only take out the ones that continue to grow. So the major errors you want to avoid is mistaking these, because that's where you can do patient harm if you call something benign malignant or something malignant benign. So I thought it'd be interesting to pick out cases in this category and talk about these possible pitfalls and talk about some pitfalls that have been made, because if you've seen them and you've heard about them, you'll probably remember them and not fall into them yourself. So we put out 5 cases, which we'll talk about today. So the first case, so you just get this breast excision and it says there's a mass. Now we put the QR codes in the cases today. So if you didn't have a chance to do this, I still find this very magical, that if you just point your phone at this symbol, like you're going to take a picture of it, but don't take a picture. You should see a little bar pop up that says Path Presenter. You just tap on that bar and then you can see this entire slide. So feel free to do that today, or these will be in the presentation that you'll have access to later and you can try it out. So these are just some photos of it. So there is some fat necrosis over here. You see a cell population, you see some foreign material. There's also the spindle cell proliferation with some fascicles. So the questions, just for you to consider, was what does the cellular infiltrate suggest about the likely diagnosis? What clinical information would be helpful to know? What is your differential diagnosis? And would you order immunohistochemistry, and if so, which ones? So Emil, I understand some of the people did make comments. Could you just share with us sort of just what the thought process was?
Well, at this point, actually, I don't have anything that is sent live during your presentation. However, I can share a few thoughts that were sent by residents and fellows since yesterday that we received. There is another one coming from one of my colleagues, and it is just in. This says, looks like macrophages and giant cell reaction, possible scar. Maybe a CD68 immunostain should be done. So that is the comment that I just received. The other comments from the residents were pretty much in the same direction. So all favoring benign, most likely the result of a trauma or maybe a possible surgical site.
Okay, well, that's perfect. That's exactly what they should be thinking about because of the mixed cellular infiltrate, the fat necrosis. So if you're thinking anything malignant, you'd have have to be thinking like there are two things going on, because you normally wouldn't see that with a malignancy, although we have seen cases like after a car accident with a patient with seatbelt trauma, and that was the first time they were found to have a breast mass. So you could have two things going on, but you're absolutely right. That would be extremely rare. So the important thing to think about, so it's an reactive inflammatory process. Just looking at the slide, you don't have a particular reason for it. We ended up getting a history of trauma. So this is probably traumatic fat necrosis in reaction to it. So in this first case, so this is to make you aware of reactive spindle cell nodules that can mimic carcinoma or sarcoma. This is just an exuberant myofibroblastic reaction, usually 2 to 4 weeks after the biopsy or trauma. You want to see the hemorrhage, fat necrosis, inflammation, giant cells, foreign material, which could be out of cysts, or if there's penetrating trauma. Most of these are small, about 1 millimeter to 1 centimeter. So unfortunately, I didn't have an actual glass slide of an error to show you, so this was the best I could come up with. This is a case that was of an actual error. So this came in as a consult case. Well, she'd been referred to the Dana-Farber Cancer Institute because she'd been diagnosed with a 9 millimeter malignant fibroblastic tumor. So number one, the first red flag is, so essentially a sarcoma. You almost never ever see 9 millimeter sarcomas. So that's a red flag right there. Also note the presence of adjacent fat necrosis. There was some nuclear atypia, there were scattered mitoses, but again, these are kind of this ill-defined cytoplasm. They're kind of scattered in the stroma. Usually sarcoma forms fascicles of tumor cells, and usually the nuclear atypia is sufficient. There's not a question. There's not a differential with possibly a benign lesion. So in this case, what was missed by the original pathologist is there's actually a biopsy site in the middle of the lesion. And so that should raise questions like, well, what did the prior biopsy show? So when we got further history, so she'd actually started out with a biopsy for calcifications that had shown atypical ductal hyperplasia, and this was a resection of those calcifications. So you can imagine just trying to put the story together that somehow she didn't have a mass by imaging, they biopsied the calcifications, and now somehow she's developed a sarcoma around a prior biopsy site. So that's just a highly, highly unusual occurrence of events. And so this is just an reactive spindle cell nodule. She didn't have sarcoma. And so this is 2 or 3 times a year we get to cure cancer. And so this was one of those cases. So it's important in the breast, particularly the breast more than other sites, is to always be aware of sort of what's going on around you or what's happened previously. So when I was a medical student, Bill Silen, so he's kind of a giant of surgery at the Beth Israel Hospital in Boston. So he was a great teacher and taught me a lot about pathology. And so, but he hated the medical team. And so when we would be rounding on his patients, and this was back in the days where the medical chart was still a 3-ring binder. And so he would pick up the medical chart, you know, when we're next to the patient's bed, and he'd be going through the chart. And if he saw that the medical team had rounded on one of his patients, he'd just very disdainfully saying, "Oh, I see medical droppings in the chart," because he knew the medical team had been there. And so now when I see things in breast tissue, I always think of these as surgical droppings. And so here's a biodegradable suture, kit gut. This is actually not made out of kit. So kit is actually a kit was actually a small violin. You can imagine violin strings are very similar to sutures. So this means a surgeon has been there, put in a suture. Here's a polyfilament suture again. Surgeons has been here. This is probably some metallic debris. These are radiologic droppings. These are the gel pledgets. So this means the patient's had a core needle biopsy. So just be aware of this. We see this more in breast than other sites because the breast often undergoes multiple procedures. And so if you see these changes, you should immediately ask yourself, why did this patient have this prior procedure? Could she have had radiation? Could she have had chemotherapy? Did she have a previous diagnosis? So there are lots of biopsy site changes that can mimic malignancy. So here we've seen a reactive stromal cell nodule that was mistaken for a sarcoma. You can get squamous metaplasia, which sort of out of context can look very malignant. You can, lesions can become necrotic. You can have epithelial displacement, so either benign or malignant cells sort of pushed into biopsy tract. You can have nuclear atypia due to radiation or chemotherapy. So it's always really important to know the prior diagnosis, and sometimes you'll get that and sometimes you won't from the requisition form. So when you're thinking, am I seeing a carcinoma or sarcoma or a reactive spindle cell nodule? So think about, so what's the site? Are you at a biopsy site? If there was a prior biopsy, so it would have been very different in the previous case if she'd had a core, which had also shown a spindle cell lesion, because then that would say that it was not a reaction to the biopsy, but had been there previously. These are usually small. Malignancies are almost always very large. Spindle cell malignancies. This is incidental. These are never, essentially you would never find a spindle cell carcinoma or sarcoma as an incidental lesion. Look for biopsy site changes. Usually these are just around the biopsy site. They don't go into the adjacent tissue. There can be mitoses, so that's not, just because there are mitoses doesn't make it malignant. So if you did immunohistochemistry, it doesn't really help you much for a reactive spindle cell nodule because they're just going to be myofibroblasts. It's usually not so much helpful either for sarcoma, unless you're thinking of something very specific like a synovial sarcoma. But if you're worried that those spindle cells in that lesion might be malignant, then immunohistochemistry can be helpful. So you've probably seen this. So if you see malignant spindle cells in the breast, what's the differential diagnosis? So these are almost all carcinomas. And so that's what you always want to put on the top of your list, and make sure that you've evaluated it and excluded those. Malignant phylloides tumors, so maybe you could just see the stromal overgrowth. They're very rare, less than 1% of malignant spindle cell lesions. Metastases, usually the primary sites, very well known. And the sarcomas are just exceedingly rare. So this is something to remember, because this is not uncommon if for somebody to do sort of your standard keratin like A1A3. So A1A3 only has low molecular weight keratins. So just remember that spindle cell carcinomas of the breast often have features of myoepithelial cells. And so they're often only positive for high molecular weight keratins. And they're often at least a third positive for P63. And so that's, tuck that away and so until you've done. So do the low molecular weight keratins too, because some of them have mixed patterns. But always make sure you include high molecular weight keratins and P63 before you conclude that a spindle cell lesion is not carcinoma. And I think that's it. So Emil, were there any more comments or?
So yeah, for the sake of time, I'll be very brief. One of the suggestions that came in was about calling this low-grade spindle cell tumor, fibroscar. So I think if it is just a biopsy, not a resection, it may be okay to say low-grade spindle cell lesion and recommend conservatory excision of the rest of the lesion if you favor this to be benign. But once you have the resection, probably you have to commit because you have to call it benign in the end. So that would be the way I would see that. Dr. Lester?
Yeah, so that was the original case that I sent out as a whole slide image was my case. And you'll find out later in the talk that I'm very sensitive to spindle cell lesions, sort of reactive looking spindle cell lesions. So I did do keratins on that case just to reassure myself that there was those reactive spindle cell lesion. Reactive spindle cells were not carcinoma, so the keratins were all negative. But you could say that's probably an abundance of caution, because I think just looking at it, there's a 99.5% chance that's just a reactive lesion. So that's great. I think all the comments that came in were very to the point, and everybody was right. That was just a benign
Just
lesion.
very quickly, one more thing. Sometimes if it is just the spindle cell component, it's okay also to call it nodular fasciitis, because it may actually show or look like nodular fasciitis all throughout. Spindle cell, feathery-like appearance of the spindle cells. Not much atypia, the most may be mild, but probably not even that convincing. So sometimes if you don't have any history of trauma, or biopsy site or anything like that, it's probably okay if it looks like nodular fasciitis to consider that.
It certainly should consider it. I have to say, it's extremely rare in the breast. I would expect it to be more cellular, more spindly cells, fewer, you don't have so much of that mixed reaction, maybe more lymphocytes out at the edge, and maybe not the fat necrosis. We actually have nodular fasciitis has USP6 gene rearrangements now, and so if you actually wanted to know, you could say from a practical standpoint, I mean, nodular fasciitis is just going to go away, and so it's wouldn't be that important to do it, but if you wanted to know what it was, we do have a molecular test for it now. But yeah, we'll come full circle. We'll come back to nodular fasciitis sort of at the end. But yeah, it is one of the most commonly, I think in that case, it's usually the differentials between nodular fasciitis and a sarcoma, and then it's of more concern as opposed to nodular fasciitis and some other benign lesion. All right, well, that was great. So let's go on to case 2. This is a 75-year-old man who was diagnosed with a poorly differentiated breast cancer, underwent mastectomy and axillary lymph node dissection. He developed a palpable mass at the edge of the mastectomy scar in the axilla after the surgery. So here it is. 2 years later, it increased in size and he underwent an excision. So here's some still pictures from it. So you can see there's sort of these complex anastomosing spaces. You can see some spindle cells, a lot of pink stuff. You can hear this is off to the edge. So you can see it sort of within this cavity. So this is based on the diagnosis that the original pathologist made. He was referred to the Dana-Farber Cancer Institute. So the questions for you was, what would be your opinion? And would you order immunohistochemical studies? And if so, which ones? So Emil, do you have some comments that came in on this case? Oh, Emil, are you there?
Yes, I was muted, but yes, one comment that came from my colleague is about the previous history in this patient. If this patient did not receive radiation, the favor would be for Masson tumor, in this case, resolving hematoma. If he did receive radiation, I would worry more about a low-grade angiosarcoma.
Okay.
And the consideration was for MIC immunohistochemistry.
Okay, these are all good thoughts. So, so the original diagnosis was angiosarcoma, but as was pointed out, this is actually a large organizing hematoma and a fibrous capsule in the axilla. So this is the whole slide. So this is a pretty big area. So if you're thinking, well, so this is essentially a Masson's lesion. It's a organizing fibrin clot, basically. So so it's not in a vessel, because this would be quite a large vessel if it was in a vessel. So what this probably is, this is probably a seroma cavity from his prior surgery, and he probably bled into it, and that caused it to increase in size. And so this is just the organizing thrombus. So papillary endothelial hyperplasia, so also called Masson's lesion. And I like this name just because it sounds so terrible, a vegetant intravascular hemangioendothelioma, but we prefer PEH. So it's just an exuberant organization of hemorrhage and fibrin by endothelial cells, but this lesion's important because it does closely mimic angiosarcoma. This is the only large series from the old AFIP. So almost 60% of the cases were sent to the AFIP because the pathologist thought it was an angiosarcoma. But when you see papillary endothelial hyperplasia, these are usually small, about 1 centimeter, but can be greater than 2 centimeters in size. They can occur at prior surgical sites. So I've seen 3 cases of PEH being misdiagnosed as angiosarcoma. So this one was at a surgical site. Another one on the chest wall was also at a surgical site. So the ones in men can be quite large, over 2 centimeters in size. And so just remember, a primary angiosarcoma of the breast in a man is exceedingly rare. And even some of the cases that have been published, when you look at the photographs, look like they were probably misdiagnoses and actually PEH. They're usually circumscribed. When we see them in the breast, you can see here's an image of a case. So this was a series that we did with cases of angiosarcoma and PH we'd seen on corneal biopsy. So so one of the striking things was after they were biopsied, some of them disappeared and some of them became smaller. And so if there are any radiologists on the line, I would love it if MC Gilbert was our fellow and Lisa Frost was the radiologist. And so if you see a vascular lesion decreasing in size after corneal biopsy, that could be the Gilbert-Frost sign. So just putting it out there. So here's a test. So here's 2 vascular lesions. Question, which one is the angiosarcoma? So take a look. You can see they can look very much the same. So this is the clue. So if you look carefully, here's some ductal epithelium. So angiosarcomas will invade into breast tissue. PH does not. So it'll, sit in this space, but it's not going to be out into the adjacent tissue. And so this is always, whenever you're seeing a vascular lesion and you don't see tissue invasion, just be very, very cautious about calling it an angiosarcoma. So just to review angiosarcoma, so it is the most common type of primary breast sarcoma. Remember, primary occur down in the breast itself. You can see it forming this large hemorrhagic mass, usually presents as a palpable mass in the breast, as irregular, ill-defined margins. And again, primary angiosarcs are extremely rare in men in the breast. Secondary, so that was good. Comments thinking about it. So he had not received radiation. If you do receive radiation and develop on angiosarcoma, it's almost always in the skin. You do get radiation-associated sarcomas deeper in the breast, but they're usually not angiosarcomas. They're usually some other type of sarcoma. So what's the thought? So in this case, he didn't have radiation. So now you're really thinking about what's the likelihood that you're going to develop angiosarcoma in a prior surgical site. So again, from the beginning, that would be very unlikely. Usually the high-grade angiosarcomas are not subtle. They're, with the nuclear atypia, they can even be solid. Spindle cell lesions can be hard to distinguish from other malignant lesions, but they're usually clearly malignant. Some of the lower grade ones can be a little more subtle, but you can see here, even here, you have these atypical blood vessels invading into fat. So that's a clue that this is a malignant vascular tumor, but you can get some benign hemangiomas that also involve breast tissue, so that alone. So you have to look for the nuclear atypia and the mitoses. I'm just going to mention pseudoangiomatous stromal hyperplasia. So this is a lesion of the interlobular stroma They're just myofibroblasts, and you see these very prominent clefts, and you can see it kind of mimic that it's infiltrating around ducts and lobules. So it's always mentioned in the differential diagnosis, but I have to say I've never seen PASH being mistaken for an angiosarcoma. So if you're considering this differential, if you're seeing a vascular lesion, so the presentation is very different. Large palpable mass with skin involvement if it's secondary to radiation. For angiosarcoma, PASH is usually small, circumscribed mass, and well, most of them are just incidental. PH is usually a small circumscribed mass, rarely greater than 2 centimeters. But again, these 3 men who had misdiagnoses actually had quite large lesions. So the cell type is important. So here the immunohistochemistry will help you if you're considering PASH, because the cells are actually myofibroblasts. It doesn't help you for angiosarcoma or PH because they're both endothelial cells. So you have to make this on the H&E appearance. Blood, again, see blood in angiosarcoma and PH, not in PASH. Nuclear atypia, in mitoses, you really should only see in angiosarcoma. And the breast involvement you'll see in angiosarcoma because it's invading, and PASH just because it's a benign stromal clefting. And MYC amplification was brought up. So yes, if someone had received radiation, that can be very helpful to look for MYC amplification in secondary angiosarcomas, but almost never seen in primary angiosarcomas. So just remember PH because it's a rare lesion, but I think once you've seen it and once you're aware of it, you're not going to fall into the same pitfall. All right. So Emil, were there any other comments on this case?
No, nothing else. I would just maybe say one thing regarding calling this papillary endothelial hyperplasia instead of calling it papillary endothelial hyperplasia, calling it intravascular hemangioendothelioma. Probably I would argue against that, simply because these days we reserve the term hemangioendothelioma for more borderline tumors that have potential malignant capability. So maybe I would stay away from hemangioendothelioma.
No, I absolutely agree. I think that's a very scary name. And actually, you can probably tell I actually like eponyms. Some people hate eponyms, but I think a Masson's lesion is also, a perfectly good name for it, and sounds very benign. So yeah, no, I second that. We should probably make that clear that I am not supporting that terminology, because I think that does make it sound much more concerning than it really is. Organizing thrombus would be, or organizing hematoma would be a fine name too. Great. Okay, so let's move on to case 3. It's a true story. A pathologist arrived at her office in the evening after a long day of presenting at a breast course. So our fellow had written up this core needle biopsy is showing invasive lobular carcinoma. It was positive for ER and PR. Some slides. So you can see there are these little rounded cells. They look like they're infiltrating as single files into this dense stroma. The ER and PR were positive. So these were the questions for your thought. So would you just sign it out as invasive lobular carcinoma? If not, what histologic features might be a cause for concern? What would be helpful to know about the appearance on imaging? And what is your differential diagnosis, and what other immunohistochemical studies would be helpful? So Emil, did you get some comments on this case?
Yes, so a couple that we just received favor myofibroblastoma here. Something that came in yesterday evening was about calling it most likely fibroepithelial lesion and suggesting the possibility of epithelioid myofibroblastoma.
Oh, that's perfect. You work with a great group. They're very, very astute. So
we are very proud people here. So
yeah. So one of the teaching points here is don't sign things out when you are tired. So I remember this distinctly. I was tired. It was a long day. So this was not a miss. but I guess I would put it in the category of a near miss. Like if I hadn't been paying attention and it had already been written up, you know, I could potentially have signed this out as an invasive lobular carcinoma, but there were features that caused me concern looking at it. So one thing, it was a circumscribed mass. So we have a really great relationship with our radiologists, and so they always tell us what they are biopsying. To my dismay, I think most of the core needle biopsy reports we get in consultations coming out, at least from the pathology report, there's no indication that the pathologist is being told what the lesion is. So that is a safety net. And it really opens up, again, a dialogue between the radiologist and pathologist. So it's really important. So in this case, they told us it was a circumscribed mass. So that, that would be really unusual for a typical infiltrative lobular carcinoma. So maybe you could see that with a solid lobular type of carcinoma, but this looked like it was infiltrating. Also, the cells didn't infiltrate around normal breast tissue, so that's another red flag. When you're considering invasive cancer versus other lesions, is always look to see, can you really see that it's infiltrating? Maybe you won't see that on a core, but that's always helpful when you do see it. I think when I was looking at the ER, it really struck me that on the ER particularly, you could see that not all of these cells were epithelioid, some were spindle cells. So I did that evening think, like, maybe this is not a lobular carcinoma, and maybe this is really a myofibroblastoma, which it is. And I did do a study for keratins, and indeed, this is an epithelioid myofibroblastoma. I think I wanted to show this case because it's not immediately obvious. I think if you're just thinking about spindle cells of the breast, that a lesion would be strongly ER and PR positive in most of the cells. And in fact, this is the only spindle cell lesion of the breast that shows that. So the peak incidence, they're 50 to 75 years old. This is unusual. It's the only lesion in which the incidence is about similar in males and females. It's just a benign neoplasm of interlobular myofibroblasts. And here again, you do have some rearrangements with loss of retinoblastoma and other genes associated with retinoblastoma. It's benign. I mean, we still take them out when we see them on core, but you could even argue that that's probably not necessary. So usually it's detected as a slow growing palpable mass or a mass on imaging. This is what it looked like. So again, a nice circumscribed mass. Here's the core needle biopsy site. So many of these have a large component of fat. Here's one of your bonus QR codes to show you an entire fibroblastoma. You can see the circumscribed borders, you can see the fat in it. If they say it's hyperechoic, so most malignant things are not hyperechoic, and so that's a testimony to having these different, it's an intricate intermingling of different tissues of different echogenicity, and so what you're seeing is the fat within areas of fibrous tissue. So that would be a clue as well. Here's the myofibroblastoma again. So these short spindle cells, again, some of them are almost completely fat. And so that's why these overlap with spindle cell lipoma, or these are probably just the same lesion. If you look at the epithelioid variant, so they look like little round cells. They do have these linear arrays that can mimic lobular carcinoma. I think important, the cell borders are sort of indistinct. They're kind of hard to see. They kind of fade into the surrounding collagen. So that sets it apart from lobular carcinomas that usually have very distinct borders and look very discohesive. You can see mast cells, not particularly helpful. So here's another test. So now that you've seen a myofibroblastoma, I mean, which one is the myofibroblastoma and which one is the lobular carcinoma? Because you can see they can look quite similar. So here, again, here's the myofibroblastoma, few spindly cells, sort of these indistinct cell borders. Here's a lobular carcinoma. You can see here, there's sort of spaces around them, so you could just see, this is it's a nice morphologic correlate with molecular pathology because these cells lack cell adhesion, so they can't hold on to anything. So you see them as these very distinct cells with spaces around them. So immunohistochemistry can help in the sense the most important thing here was to show it was keratin negative, which eliminated the possibility of a lobular carcinoma. It's in the CD34 positive family. They're myofibroblasts, so it'll be positive for muscle markers. You could do RB, so most of them are negative. I don't find that particularly these negative markers are not as helpful as the positive ones. And again, just remember, so over 60% of the cases show strong ER/PR positivity. So that's actually helpful when you're thinking of myofibroblastoma versus other lesions. And this is just normal myofibroblasts are positive, and smooth muscle is also positive. So this is just a characteristic of normal myofibroblasts. It's not something newly expressed by the tumor. You might think of solitary fibrous tumor. It's much rarer than myofibroblastoma in the breast. This is this sort of patternless pattern of these small spindle cells. You see these large vessels, staghorn vessels. It would be negative for hormone receptors. So in this case, just knowing that it was positive would exclude a diagnosis of solitary fibrous tumor. It would also be positive for RB if you did that. So this is another one of these interesting lesions that has a specific gene fusion, and we have a STAT6 antibody now, if you really wanted to know, or that was in the differential diagnosis. So you have lots of things to help you with myofibroblastoma versus an invasive lobular carcinoma. So the shape and the margins, the cells, which we've talked about. So this is a case where the hormone receptors will not help you. The keratins are going to be what helps you. If you did muscle markers, they would be positive in myofibroblastoma and not lobular carcinomas. BCL2 doesn't help you. Epithelial membrane antigen doesn't really help you because they both can be positive. So to sum that case up, so now that you know about an epithelioid myofibroblastoma, I'm hoping no one would be fooled by that in the future. Okay, did anything else come in?
Nothing else. The only thing that I would like to mention is that glomus tumor was considered by somebody yesterday evening also in the differential. Glomus tumor can be considered, of course, especially in a biopsy, but expression of estrogen receptor is incompatible with glomus tumors, and that should move you toward myofibroblastoma.
Well, and I'd say if you ever see a glomus tumor in the breast, please let me know, because I have never seen one. So it could be, there is this whole category of things, very superficial lesions. So nodular fasciitis is in this group. So they're sort of in the breast, but they're actually in subcutaneous tissue. So, but that was a good thought. Great. So let's move on to case 4. This was a 60-year-old woman who presented with nipple discharge, and she underwent a retroareolar excision. The lesion was signed out as a large duct papilloma with infarction and inflammation. So the question, what would be your diagnosis? Would you order immunohistochemistry, and what would you request? So Emil, what comments did you get on this one?
So the comment that I just received, atypical spindle cells and epithelioid cells are present. I would be worried about angiosarcoma if any history of radiation therapy. Okay,
that's good. So it's good to recognize there's something bad going on here. So this is a mistake that I made. And the story really starts 6 months later. So this was 1994. So the patient returned with a palpable breast mass. So another faculty member had the case and was puzzling over the biopsy because it showed this malignant spindle cell neoplasm. And the patient had had a history of melanoma, so they were trying lots of melanoma markers and epithelial markers, and they just could not classify the lesion. So I was interested in the case. It was an odd, spindle cell lesion of the breast. And so I went back and looked at the history. So again, this is to make the point, sort of knowing the situational awareness, sort of like know what's going on. So when I looked in her history, I was very puzzled that I had seen this papilloma with another faculty member 6 months prior to that, and both of us had thought that it was an infarcted papilloma and it was signed out that way. So I was curious, like, that's so odd that then 6 months later she would develop this spindle cell carcinoma or spindle cell lesion. So I went back to the file, pulled the slides. So this is somewhat, so there were 4 or 5 blocks of this large papilloma. This was only present in this one slide. So this, I guess, it would have been helpful if maybe I should scan all of the slides. So in the other slides, it was more obviously a papilloma. This shows, this is almost all infarcted. So when I looked up the case, I can still remember this very distinctly, seeing this area, and your heart just falls when you see something like this. So what this is a spindle cell carcinoma mimicking reactive stromal cells. So you can see these in cystic lesions, inflammatory lesions, infarcted lesions. So this is squamous metaplasia. And then these cells deeper to it, we had originally thought were just reactive cells to the infarction. But when you really look closely, there's marked nuclear atypia, there are mitoses. So this was clearly a malignant lesion. So we went ahead and stained it for keratin and P63 and showed that we could still see keratin positivity, showing that this was a spindle cell carcinoma arising in this infarcted papilloma. So she'd recurred 6 months after the excision of a spindle cell carcinoma arising in association with an infarcted papilloma. So for her diagnosis and care, at least now we could say that this was recurrent carcinoma, and she did not have stage 4 metastatic melanoma. And she was treated appropriately for a triple negative carcinoma. So I learned a lot from this case. I've become very, very respectful of things that look like reactive spindle cells next to lesions. This goes back to the first case. So maybe I've become oversensitive to this by staining what looked like reactive stromal cells, but at least to my knowledge, I haven't made this mistake again. This is another case, whoops. This is another case. This is a cyst. Here's some squamous metaplasia on the edge. Again, kind of reactive looking cells. So you need to look at them carefully. And if you see stromal cellularity and mitoses, you should have a low threshold. And again, you want to use high molecular weight keratins and P63 in addition to low molecular weight keratins, so you don't miss a spindle cell carcinoma, because these are bad carcinomas. So they're 20% of metaplastic breast carcinomas. Again, they're very similar to myoepithelial cells. High molecular weight keratins, P63, they can also express muscle markers. Another possible pitfall is if you do D240, thinking or potoplanin, don't use that as a vascular marker, because that's also positive in myoepithelial cells and can also be positive in spindle cell carcinomas. So these cancers rarely go to the lymph nodes, but they commonly go to have distant metastases. They don't respond well to chemotherapy, and they frequently cause death of the patient. So you really don't want to miss these. You do need to distinguish these from adenosquamous carcinomas and low-grade fibromatosis like spindle cell carcinomas. As these cancers, even though they're spindle cell carcinomas, have a much more favorable prognosis. So when you're thinking, is it a reactive stromal cell or is it spindle cell carcinoma? So both of them can be adjacent to cystic lesions. Be particularly careful when there's an area of squamous metaplasia. Usually nuclear atypia is present and marked in carcinomas. Mitoses can be present in both. Oops, look at that. Again, make sure you do both high and low molecular weight keratins and P63. CD34 not particularly helpful. And again, muscle markers can be positive in both. So just be really careful. As my colleague Stu Schnitt likes to say, it's great to learn from mistakes, especially when they're somebody else's. So I'm sharing this one with you. Please be careful when you're looking at these reactive spindle cell proliferations. Okay, Emil, was there any other more comments?
No other comments. I just want to mention that yesterday evening, two of our trainees actually favored this to be a spindle cell carcinoma or metaplastic carcinoma. So we have all the reasons to be very proud of our trainees.
Absolutely. No, that's great. That's wonderful, because to pick that up, you know, just be very careful around these reactive lesions. That's great to hear. All right, then we have our last case. So this is a woman with a 1.5 centimeter mass with spiculated margins. She underwent corneal biopsy. So the question is, what's your differential and what immunohistochemical studies would you request? So Emil, did you get any comments on this case?
Nothing yet. So I think we'll reserve the comments for the end. I can say that yesterday evening's trainees favored this to be most likely either myofibroblastoma or maybe metaplastic carcinoma. So one was in favor of myofibroblastoma, the other metaplastic carcinoma.
Okay, well, those are all great thoughts. Again, going back with the spiculated margins, so that would make myofibroblastoma unlikely. But it is a spindle cell lesion. Yeah, so it's wide open as to what this could be. I wanted to show this because this is a very sneaky, low-grade fibromatosis like metaplastic carcinoma, mimicking fibromatosis or other benign lesions. So what you want to remember with these, when you see these, make sure you do high molecular weight keratin and P63, which are done here. So this showed that this was a carcinoma. So this is a type of metaplastic carcinoma, usually older women, has not gone to lymph nodes, but it can recur locally. So prognosis is better than other metaplastic and triple negative carcinomas, but there have been rare cases of distant metastases and death in these large cancers. The other thing on core, sometimes on the core they look like a fibromatosis like carcinoma, but on the excision they're actually a higher grade spindle cell carcinoma. So you don't want to miss this on core. So here's some more pictures of it. You can see it can look very much like fibromatosis. You can have areas of lymphocytes out at the edge. They're very bland looking tumor cells. Beta-catenin is not very useful, as some carcinomas also have nuclear positivity. And so just because you see nuclear positivity doesn't make it fibromatosis. So the keratins are really the most important. The keratins at P63. So when you're comparing them, if you see epithelioid areas that favors a fibromatosis-like carcinoma, mitoses can be present, but they're often rare, so it's not really helpful. Keratins are your most helpful with P63. Again, nuclear beta-catenin doesn't really help. They're both negative for CD34, because this is the CD34 negative family. Muscle markers can be positive in both. ER is negative in both. So they both can recur locally. Fibromatosis does not metastasize, but these carcinomas can rarely, and again, some of them are actually higher grade when you take them out. So right now, so many cases of fibromatosis don't progress, and so at the Brigham, many of these women are put under observation after corneal biopsy. So that's why you really, really want to make sure you've done everything you can to exclude fibromatosis like carcinoma. So we do a full panel of markers on these cases. Here's another bonus case to show you this is a nice case of fibromatosis. So you can see it can have these spiculated margins. It can look very much like a invasive carcinoma on imaging. And you can see this infiltrative pattern around normal breast epithelium. But it looks a lot like the fibromatosis like carcinoma, where they both look like each other. So it has these long sweeping fascicles. Here you see the irregular edge. When nuclear beta-catenin works, it supports the diagnosis, but it's often focal and weak. This is actually the exception to the rule, where you see very beautiful nuclear staining out here in the fibromatosis and the membrane staining in the normal epithelium. So don't expect this. Usually they're very hard to interpret. And you can also see these in other spindles. You can see nuclear positivity. So it's not very helpful. I actually find what's more helpful is the absence of CD34, because it's really the small family of fibromatosis and nodular fasciitis in the breast that's CD34 negative. But spindle cell carcinomas are negative, so in that differential, it doesn't help. It only helps if you're thinking of other spindle cell lesions. I just threw this in with nodular fasciitis because, yes, this is a big problem at other sites. This is a nice recent paper. A third of them have been misdiagnosed as sarcoma. It's really rare in the breast. So this was technically called a breast lesion, but you can see on excision, it's actually sitting in the subcutaneous tissue. It's CD34 negative, like fibromatosis. You know, sort of, again, a sort of a patternless pattern of this tissue culture look to the spindle cells. You can see mitoses. Extravasated blood cells is a useful sign. And now we do have this molecular test if you really want to know whether it's nodular fasciitis or not. So to sum up, we've seen these 5 cases. This is just a summary of the immunohistochemical studies that we usually do for these lesions and their staining patterns. And we've talked about how they're helpful in the differential diagnosis when you're in these difficult cases. So the take-home points: all pathologists make errors. So for your trainees, everybody makes errors. It's not the end of the world. Just think what's the best thing to do for the patient, learn from them. And I really would like to see more in pathology to use errors to help teach pathologists more about how to avoid them, because being aware of potential pitfalls helps pathologists avoid them. So I've shared 5 difficult cases with you today. And so now that you've seen them, hopefully you will not fall into them yourselves. Definitely show cases to other people when you have the opportunity. That's always helpful. I was kind of grateful that I had shown, well, another faculty member had shown that infarcted papilloma to me, and both of us made the mistake. So at least I felt like, you know, it was a difficult case. Always be aware of droppings in tissue, because these can provide important clues for the clinical history and the etiology, and this creates a safety net. And the same thing about knowing more about what the lesion looked like on imaging. So by collecting this information, by knowing the sort of the situation around the biopsy and around the patient, it makes it much less likely that you're going to make a mistake. Don't sign out when you're tired. You know, there's a lot of pressure for people to do that, but not a good idea. Go home, enjoy your family, come back the next day. And then finally, yes, I think reviewing errors are a great way to improve practice, because everybody makes them and we need to share them with other people. So I have a final mimic. Is this Stonehenge in Salisbury Plain in England at the solstice? Or it's actually Cheesehenge in West Roxbury, Massachusetts. So this was invented by my husband. This is a henge made out of cheese. This is my daughter's hand. This is the ultimate cheesehenge cheesehenge photo. So this has become a tradition in my family at the winter and summer solstices to make a cheesehenge. So yes, so this is not the real Stonehenge. This is another mimic. So thank you for your attention. If people can hold on, I'd be glad to answer questions. And I thank you all for giving me this opportunity to talk to you today.
Thank you very much, Dr. Lester. We are at 9 o'clock, so one question that came about, I mean, for those who have to leave, please feel free to leave. Those who have more questions, please ask them as they come around. Other questions, I will compile them and send them directly to Dr. Lester so she can answer them for you. So one question that came was why fibromatosis like carcinoma occurs more often or most often on the left side, on the left breast?
You know, it's a wonderful question. It's like every study of a breast lesion always lists right versus left. This was the only one, I think, where it actually seems predominantly to the left. I have no idea. If anyone else can even come up with a possible explanation, please let me know, because I have no idea why a lesion would be more common on the left than on the right.
And Dr. Khalifa, who is the director of anatomic pathology here, he would like to say a comment.
Thank you, Dr. Lester, for a very fantastic lecture this morning. I just want to point out one aspect to our residents. You have just witnessed classic teaching of anatomic pathology and the approach of first reviewing morphology, come up with a differential, correlate with clinical findings and radiology, and then request immunostains. Antibodies help you when you already have a differential diagnosis. Dr. Lester's presentation today is spot on with that concept. Thank you, Dr. Lester.
Well, thank you so much. And yes, that's a great point. We call it trolling a case through the immunoperoxidase lab. So you just, if you have no idea what you're looking for and you just like order dozens of stains. And I think a corollary to what you're saying is that anything can stain for anything some of the time. And so if you start ordering stains without knowing really what you're looking for, you may very well come up with the wrong answer. So it's an excellent point.
There are multiple thank you messages for you, Dr. Lester, in the chat.
Okay, well, thank you. This is really, really delightful. And I hope I can make it out to Minnesota soon.
Yes, we hope so. We want to see you in person here.
Yeah, it'd be nice to go back. Well, my older sister, Marty, still